disclosure information, please refer to your program supplement.
Hello, and welcome to the Partnership for Patients Education Series, brought to you by the Vizient Hospital Engagement Network. Today, we're taking a look at the process of informed consent in which a physician advises a patient of the risk and benefits of a proposed treatment before the patient agrees to it. Too often, physicians and hospital administrators consider it a formality as a legal requirement and a liability safeguard. It's just one more item on the checklist of a busy day. Yet routinely, the process truly doesn't work for patients. Maybe they aren't clear on the risk and benefits. Maybe they aren't given the time or the information to make their own decision, but feel hurried into it. There is a growing awareness that the process can and should change for the benefit of the patient and physician alike. Today, we'll examine the new rationale of shared decision-making that leads to authentic, patient-centered informed consent. This approach advances a true partnership between the physician and patient to the welfare of both. I'm Dr. Robert Dean, Principal of Performance Management and Physician Resources for Vizient, and your moderator for today's program. We're broadcasting live from the Vizient studio in Irving, Texas, and we're glad you're with us. Let's get started. Before we begin, let's review our learning objectives. After viewing this program, you'll be able to define the role of physicians, patients, and the healthcare system in the process of informed consent. Describe the elements of the communication process necessary to achieve informed consent, and identify tools and resources to healthcare professionals to improve informed consent communication process. You'll find supplemental information on our website. Please visit the address on your screen to see the slides from today's program and relevant content that you can download at your convenience. You're an important part of our program and we want to hear from you. Here are two ways you can join us. First, you can chat with us online. If you're watching on the web, send us your questions or comments at any time. Just type your message and click submit. You can also email us at visientvideo@vizientinc. That's a mouthful. Whatever's easiest for you, please join the discussion. One more detail. We've posted program resources on the Vizient website for your reference. Now, let's meet our special guest. First, Dr. Peter Angood. Peter, welcome to the program. Please
Great.
Tell us about your background and your contribution to today's show.
Sure. Well, thank you, Robert. It's a privilege to be here today, and I'm currently the President and CEO for the American Association for Physician Leadership. 40-plus year organization focused entirely on leadership education and management training of the physician workforce. Prior to that, however, I spent 25 years in academics as a surgeon doing trauma and surgical ICU work. And then I spent the better part of a decade doing national and international work in patient safety and quality with the Joint Commission, World Health Organization, National Quality Forum, and others. This is a topic dear to my heart, and I'm really happy that we're here today. Thank you.
Thank you, and we're glad you're here with us as well. We also welcome back today Marty Hatlie. Marty, welcome, and please tell us about your background and your part of today's show.
Great, thank you. I'm Marty Hatlie. I'm the director of the MedStar Institute for Quality and Safety. MedStar is a 10-hospital system in D.C., Baltimore, and Greater Maryland. I'm a lawyer by training. I've actually defended malpractice cases earlier in my career. But my real passion now is the partnership that you mentioned, Robert, in the introduction between patients and families and providers in getting the best results. And I'm happy to be here today.
Thank you. Welcome back. Finally, we have with us Patty Skolnik. Patty, welcome, and please tell us about your background and why you're here with us today.
Thanks, Robert. Well, first, I'm a recovering social worker and Since then, I am the founder and president of Citizens for Patient Safety. And this organization was founded after the preventable death of my only child, Michael. Our mission is to increase engagement between patients, family, care partners, and providers for better health outcomes. And this topic is also very dear to my heart, and I'm excited to be here.
Welcome. Peter, to get us started, can you briefly define what we mean by informed consent?
Sure, by all means. First off, informed consent is part of the shared decision-making process that we're all evolving to, and it's a process, and it's where we discuss a condition, what is that condition all about, and then what are the treatment options and the consequences of the treatment or the lack of it. As a part of that conversation, you have to go through the benefits, the risks, the potential harms of the treatment, but also to make sure that we cover the alternatives, of which one might be to do nothing.
Okay. Marty, what has informed consent look like from a traditional approach?
Robert, informed consent has its basis in ethics. Human beings are the owners of our bodies. We have to give permission to people to touch our bodies or do things with our bodies, including consent to medical treatment. The original intention of informed consent was to form a meeting of the minds between patients and families, between patients and their providers, so that we were on the same page, frankly, in giving that consent. What's happened over the course of time, however, though, is that process has been documented in, for the record. That documentation has become increasingly legal. And I think the drift that's happened, the evolution, if you will, in informed consent has been towards it feeling like a legal document now, like something that you just sign as part of a process, and it's taken us away from that real core content of being about that formed decision, that meeting of the minds between patient and provider.
Mm-hmm. Well, and certainly us as providers like to blame the lawyers for most everything, so thank you for saying that.
Yeah, well, you're welcome, Peter.
Well, if you see that little cartoon that's up on the screen or coming up, that is the epitome of the traditional way of giving an informed consent. Unfortunately, the traditional way is a one-way conversation, physician to patient. So, you know, when we want your opinion, we'll give it to you. And hopefully we are moving away from that. We'd like to be at greater speed, but we're working on it.
Yes.
So appropriately, you're blaming the physicians now, so thank you for that.
You're welcome, and yes, I am.
Marty, can you talk to us about the limitations of the document itself?
Sure, Robert. I'm going to actually beat up on my own tribe here because it has become a document that is so steeped in legalese now that it's hard for, I think, many patients or their family care partners to understand what it is. It's complicated. It can be very fragmented. It's sometimes given to you in multiple documents. Sometimes the process is delegated so that it's actually not even given by the physician who's the head of your team. It's given by somebody who may not even have read it. People honestly don't know what they're signing anymore. It's lost its meaning, this documentation, in many ways. So again, the process of legalization, the protectiveness of the legal language has gotten us away from the true intent, which is that shared meaning of the minds.
And Peter and Patty, you've already started in a little bit here, but can you give us the perspective from the physician and patient on other issues around informed consent?
Sure, and you know, all teasing aside, I think we have to recognize that this actually is an evolving aspect of healthcare. It's an important one, and it's really been, I think, pivotal in the last couple of decades for us to recognize that we have to have these conversations, and that each of you need to have these conversations in your own environment. So let's work with the evolution of it all. As Marty was alluding to just a moment ago, actually, the physicians and other providers really don't know or understand the content themselves. They've got a document that they want to have signed, and so there needs to be some ongoing education in there. Couple that with all of the pressure of really obtaining these consent forms, checking a box. There's production pressures for everyone at all levels of the work environment these days. And then the last comment I would say is that, you know, oftentimes the providers forget and they don't quite fully understand a patient or that sense of dependency that the patients have on us, and so they want us to engage in these conversations better.
I agree totally with what Peter is saying. I think some other things that we need to remember is the literacy level of the patient. How much do they understand? Are you doing teach back with them so you know that they're understanding what you're telling them? Can they read it? Is the font size big enough if there is a visual impairment or a senior that may not have their reading glasses? The cultural and ethnic background of the patients comes into play. And when it's given to the patient, who else is in the room? Are they feeling rushed because there's somebody there from the OR waiting to take them on the gurney and take them to the OR? Or are there family members there that have questions and want to be able to ask them?
With these, I'm sorry.
Robert, if I could just interject one last piece. I think all these limitations have created a sense of distrust, almost. This document looks like something we're hiding behind versus what it was really meant to do, which was bring us together so that we're on the same page.
Right.
Well, but there's the opposite side of that. You know, as we go through our daily lives these days, all of us are faced with a plethora of, you know, releases, waivers, consent forms, and so there can also be this laissez-faire attitude of it's just another document, so where's the X that I need to sign off?
This is what I need to do to have my procedure
Yeah,
done.
absolutely.
With those limitations in mind, what kind of challenges do patients and families see when they or encounter when they first see a consent form?
Well, first of all, the first thing would be when you first see the consent form is when is it? And as I said previously, is it right then and there and you're going right into the operating room? The best scenario, in my opinion, would be, you know, you go to the doctor's office or to a pre-op clinic, you're given the consent form a couple of days before your procedure is going to be, and the patient has the time to read it, go over it with their family members or care partners. They are not rushed. They can write down their questions, come back, discuss it with their healthcare professional, and for everyone to realize this is not a single event. This is a process, and it should be done as a process, and it's not just an event. And once we get that, I think we will move forward more quickly.
Right.
I think in addition to what Patty just described, you know, it would be ideal if it's a totally elective situation and there is time to deliver it 2 days in advance, to have one or two or more conversations as needed. But we have to recognize as well there's different levels of acuteness of illness and there's different urgencies around the treatments required. So a truly emergent situation is one type of scenario, but then a truly pure elective, semi-elective is another. So we have to be able to adjust based on the acuteness of that illness and the pressure of that treatment plan. And we're doing this in what's historically a highly paternalistic type of a system. So how do we learn to bring in and accommodate ourselves better with accommodating language differences, education, proficiency, age, as Patty said. Has the patient been sedated? What's their reading level? And, you know, even what's their core intellect? How many of these different factors are in there while providers are doing work in a pressured environment? And, you know, there's always a number of people walking around where patients may or may not be comfortable having that happen.
Peter, Robert, Patty, I think we also have to remember that, you know, we're not at our best when we're patients and families in this process. We're ill, we're worried, we're anxious, we might be medicated. So we don't listen as well as we do in other aspects of our life. And there's just too many providers sometimes in the process. That can be a problem as well. And it keeps us from getting at the core of what we really want to be discussing here, which is understanding the risks, understanding the benefits of the treatment that we're consenting to.
And I think, Marty and Peter, one other thing we have to have in place because of that, of the patient being anxious or in pain, is that's why there needs to be a family member, an advocate, someone else that is there as an extra set of ears.
I couldn't agree more with that, Patty.
Absolutely.
I think that's absolutely correct.
So here in the conversation so far, I have to ask, does anybody benefit from the informed consent process at this point?
Well, not in my opinion. Or I should say, in my opinion, the physician is the one that benefits in the traditional informed consent for fulfilling his or her legal requirement. And I think that's what it is, and I see it continuing to be that. Hoping, of course, as Peter has suggested, and Marty, that this is changing.
With all due respect to my colleague Patty, I'm not sure either the physician or the patient benefits from the process as it currently works.
Well, I hate to say it, but I disagree with both of you. You know? and I think because this is a changing process, we actually have pushed the issue to the forefront, and that's shared decision making. How do we make a better informed consent overall? And so this is, as unfortunately is often the case, it's process improvement in action, but it takes a period of time to get there. So we're making improvements.
And how would you characterize some of the pressures that are currently influencing that process as it stands today?
Sure. You know, well, we've mentioned productivity a couple of times, and that is not only at that physician level, but it's at the nursing level, other care providers. There's really, you know, within a practice environment or within an institutional and organization procedure environment, there's this pressure to put the cases through as efficiently as possible, and then how do we really make sure that we're gaining as much productivity overall. So that creates this time pressure. But then on the other side of it, there's this paradox of documentation. And we now know that at times, you know, for 1 hour of patient care, there's at least 2 hours of documentation required. And now you've got this shift going on in healthcare from the so-called volume-based type of care to a value-based type of approach. And we really don't know what that financial reform impact's going to create. And couple that with, you know, patient satisfaction scores, et cetera, my point is there's a plethora of external pressures that go against having some focused, meaningful time to talk about these things.
Informed consent.
Yes.
Yeah, I couldn't agree more. The financial and time pressures are real. There's also the protectiveness of the language. It really kind of communicates a risk manager point of view. And I think it does put both physicians and patients in a box. I mean, there's these competing demands sometimes for the physician that makes you want to go forward as fast as you can. And what we think needs to happen here is that it needs to slow down into a real conversation. So you take the time you need to get on the same page.
Patty, can you describe for us what our traditional approach has brought us so far?
Sure. I think the best way for me to describe that is to tell you the story of our son, Michael. You know, Michael was a 6'4", bright-eyed, 22-year-old, and born in 1979. Normal pregnancy, normal birth. He was our only child, and he loved the medical field. He was a vet tech, an ENT, studying to become a pediatric nurse when our train wreck began. And Michael passed out, and we took him to the ER where he had been told that he had a seizure and probably had a tiny colloid cyst that was asymptomatic. And they told us to take him to see our primary care physician and have him do a workup for a seizure disorder. The next step after seeing our physician was to see a neurologist. And instead of seeing a neurologist, we were referred to a neurosurgeon. And being a layperson at that time, I thought, great, top of the food chain for a consult, this would be the best. Unfortunately, it didn't turn out that way. When we spoke to the neurosurgeon on the phone, he said that Michael was lucky that he didn't die when he passed out, and to bring him into ICU for observation. And we were terrified because it was such a minor incident for us at the emergency room. So upon visiting the doctor in the ICU, he's showing us a CT scan, and he says, here's the little dot, and Michael's ventricles are enlarged because that little dot is keeping the cerebral fluid from flowing, and that he needed to have a ventricular drain put in immediately, and he was to have brain surgery within the next 48 hours, or again, he would die. So he told us it would be a 6-day hospital stay, a little bit of rehab, and Michael was going to be fine. And that's what we certainly wanted to believe as parents. So we proceeded with the surgery, which was to be 3 hours. And 6.5 hours later, the neurosurgeon came out to the waiting room, and he bent down on one knee and he pushed his hat back. And I quote, "This has been the worst year of my life," is what he said to us. And we asked, "How is Michael?" And he said, "I never found the cyst, and I did heavy manipulation of the brain." And at that point, I don't think David and I even heard him. And the story goes on, and it's a very long story. The 6-day hospital stay turned into 5 months in ICU and 22 months in 5 other hospitals in Denver and California. From it, Michael never walked, Michael never talked, cried, laughed, or ate again. He was partially blind, he had no short-term memory, and he was psychotic. He was like a 6'4" infant. He was not the child that walked into the hospital. The story ends with us bringing Michael home to our own ICU unit for the last 6 months of his life, at which point we had to make a decision as to whether to put him back on life support due to him having a grand mal seizure on a nurse's watch when he had fallen asleep. He did not know it. Michael aspirated and got pneumonia. So Michael could spastically move his right hand, kind of like this, and try to get it up to his head and shoot like a gun. And with no short-term memory, he did it repeatedly, and we would say, Michael, stem cell research, give us 2 years. And he was able to give us a thumbs up. So we felt we actually knew what Michael wanted, and putting him back on life supports was probably not the right answer. This is not a decision a parent should have to make. Putting your child on a morphine drip and laying with him and listening, because you do hear it, even if it's just in your own head, drop by drop. Michael, many hours later, opened his eyes and mouthed, "I love you," and took his last breath. This all occurred because we were never given our options, our risks, our benefits, our alternatives, or true informed consent.
Patty, I speak for all of us, and I'm very sorry for your loss. Sorry. With that in mind, and what you know now, what could have and should have happened?
There were many opportunities, Robert, where shared decision-making, the conversation, the two-way conversation should have and could have occurred. My husband and I at the time didn't know what we didn't know. We therefore weren't aware of the questions we should be asking, and we put our total trust in the physician. We honestly believed he would be doing everything in Michael's best interest.
Peter, this happened 15 years ago. Have things improved?
Well, I'd have to say, unfortunately, no, but also fortunately, yes. You know, as a result of a story like Patty and David's family, there are others, unfortunately. And those of us who have been clinicians, and I saw it, unfortunately, looking after the ICU for many, many years, that, you know, things just sometimes don't go well, and there's a lack of good information. So we have had some efforts towards improving it, but there still are very many solutions required. We've got a long ways to go, and really, in order to break this historical pattern. A couple of facts on some recent research that demonstrates how far we have or perhaps have not come. Some research has looked at the audio recordings of that informed consent process, and one study shows that less than 9% had all of the elements for an intact, good, strong informed consent. Another study showed that while 45% of them may have had reasonable elements, 23% of those actually didn't have the basic elements of an intact informed consent. Another aspect of this is the variable content, and one study looked at 157 different hospitals and their informed consent forms. 74%, 3/4 admitted any reference to any sort of procedure that the patients and their families had consented toward. And then finally in this, and there's lots more data, the reading level of these consent forms are often at much higher than a grade 12 level. And when you do follow-on studies with patients who have undergone procedures and then try to get a sense of how well they understood their consent process, very poor comprehension afterwards.
You know, the legalese that you're talking about, Peter, we've already talked about, but what's encouraging to me right now is people like Patty who come forward, and in audiences like the one we're having with you today, are proactive. They bring a sense of urgency to the fact that we just shouldn't be waiting any longer to fix this problem. And I think the other good news is there's a readiness for change by many of the physicians and the nurses and the providers in the organizations like you. That readiness is there for physicians, it's readiness is there for patients increasingly, and it's getting integrated into our public policy. So there is, I agree, Peter, there's a lot of, most of the journey is ahead of us, but we can go faster than we've gone before.
Yeah, and I would totally agree with this receptivity piece. Now it's just a matter of how do we coordinate the individual providers' intents, the organizational intents, and the expectations of the patients. We're on the precipice of doing something really good. We just have to get there.
Right. So we've spent much of the beginning of the program talking about the deficiencies of the current state. We recently interviewed Dr. Harlan Krumholtz at Yale School of Medicine about not only the current state, but also how to improve shared decision-making and informed consent. Let's take a look.
Informed consent began as an intent to make sure that people knew what they were getting into, that we were doing a good job making sure that people had agency over their bodies, and that the procedures that they were undergoing were ones that they chose to undergo. It grew out of some concerns around ethical improprieties, both in research and in clinical care. But it evolved as a legal document, a way to protect ourselves, a document to get signed expeditiously. And maybe it lost some of its original intent. We saw it as a task to be completed, something on the checklist to get done with, but not something necessarily be done in a way that ensured that people truly understood what the potential benefits were going to be of what they were contemplating, and what the risks were, what the alternatives were. And actually, even more than that, what about this place? What's the experience of this place with this? What am I likely to be at risk for financially as a result of this procedure? I mean, these are real questions that people have and are rarely addressed. And so in a perfunctory manner, many of us were taught, just get this done, get this thing signed, put it in the chart, and now you can proceed to the procedure without having to verify that people truly understood what they were getting into. And it could stand as a reason why people end up being pushed along a path that if they knew all the facts, they wouldn't choose. And so we have to be particularly careful and thoughtful and attentive to those populations that may have a reason why it is even more difficult to communicate, even more difficult to understand. And it's up to us, the medical profession, up to us, the healthcare systems, to ensure we're delivering that information in a way that's accessible to people. Not just put the onus on them, well, I'm not sure why they didn't understand, but to assess the success of our efforts and to test whether or not we're being successful in conveying that information. And so I think as practitioners, it's not just a matter of telling clinicians you just need to do this better or you need to spend more time on it, but we need to develop systems that support us. We need to find ways that in the interludes when people are waiting, whether it's in the waiting room or at home or in other venues, they get a chance to be educated, they get a chance to see information, they get a chance to reflect, that we get help from other healthcare professionals around us to answer questions. We get help maybe for people who've been through the procedure to provide mentorship to people who are contemplating a high-stakes decision. We have to be creative and innovative about this, because if the solution is simply to look at the clinicians and say, you're not doing a good job, spend more time with patients, then we're unlikely to be successful. The idea is that this involves a team effort. It probably involves some training. It probably involves some technology. But we need to be smart about this if we really want to achieve informed consent. And the truth is that from the patient's perspective, the anxiety levels are sufficiently high to probably cause transient cognitive dysfunction. You just don't hear as well. You don't process information as well when you're in a nerve-wracking situation talking to your doctor about a high-stakes procedure. We need to find ways to be able to give people the opportunity to listen, learn, outside the context of sitting with us, and then provide the space for them to ask questions of healthcare professionals, get the answers, and recognize that informed consent is not a one-time, quick interaction, but it's a process. And then we need to be able to provide that for people who are contemplating this. We need to be able to be sure they know their options, and we need to be able to be sure they know the facts. It shouldn't be a polarized debate where there are activists on one side saying patients are being mistreated on the other side with regard to the way we're doing consent, but we need to come together and say, within the constraints that exist within the healthcare system, how do we move together to ensure that choices are truly informed, that there's been an opportunity for people to understand the risks and benefits, that they've been able to participate, and that most importantly, they know their options. Too often, patients are being told, this is what you need to do. your life is at stake, this is what you need to do. When in fact there are choices that reasonable people might choose that have different balance of risks and benefits to them and should be acceptable to the healthcare profession. This isn't a matter of me telling people, you need to do what I would do. This is a matter of me helping them make the choice that's in their best interest. So advocates, caregivers, patients themselves need to open up these conversations and say, time out, I may not understand well what the risks and benefits are here. I may not understand well what the options are. So on their side, in a respectful manner, it's important that those questions be asked. And they need to know that those questions are never out of bounds. They're never out of bounds. And there's always the opportunity to find someone who will entertain those questions. And if you're talking to somebody who doesn't, then you need to know that you should be able to go and find another opinion. Because these high-stakes decisions are key for your life, and that we need to be able to, as healthcare professionals, to be open to those kind of questions. But an ideal system doesn't put people in the position where they have to push. We should have a system where they're invited to ask those kind of questions, where they're made comfortable to ask those kind of questions, and where it's normative for those kinds of questions to occur.
A very impactful video, one full of content and lots to discuss. I love the reference to process and systems. Really brings me back to high reliability science, where we put the emphasis on process, not people. We fix that first, and creating more supportive systems that invite questions and the search for more information, and also relying on team members for informed consent. Mm-hmm. Your thoughts?
Well, I think, you know, what Harlan's really helped us become is more aware of a variety of issues and the need to have ongoing, increasing education. If we really want to continue moving forward in the development of solutions and consistent use of solutions, then we have to break with our historical patterns. And it's awareness, if you will, needs to come at all levels, and that is at the board, at the C-suite, all the way through down to frontline workers who are actually delivering care and obtaining these consent forms. So it's this shift of a risk management approach, protecting, to a shared decision-making, working together. So we have to ask ourselves, what do individuals do in this? What do the organizations need to do? And how do we bring this together so that there's a better consistency of an approach different from historical patterns?
Robert, I want to underscore what Harlan said about leadership. I mean, he is a leader. He's speaking out. That reflects the shift we're seeing. So for leaders in this audience, write this down. If you're a leader, it's up to you to put that system in place in your organization, no matter how big or small your organization is, to make the conversation that has to happen doable, easy to happen. The EMR, the signature, the form is not a substitute for the conversation that has to happen to get on the same page.
And Patty, one of the things Dr. Krumholz talked about was the ability to get more information, including a second opinion.
Yes.
Talk to us about what role a second opinion can play.
You know, a second opinion is of the utmost importance. And what I tell patients, family members, and care partners is just that do not feel intimidated. The value of getting a second opinion is what Visa says, and I can't think of the quote right now, priceless, and it is. And unless it's an obvious emergency, you need to stop, you need to collect yourself and say, we need to have a second opinion. Just as you get 3 estimates for work to have work done or your job or your home life, the same applies, and even more so in medicine. Consumers need to be taught what questions to ask, and the most important is, do I want to get a second opinion? David and I have such guilt because we did not follow that, and we were intimidated and we didn't push for it. So, you know, just do it.
Okay. Another aspect that Dr. Krumholz talked about was creating new attitudes and a new cultural environment for information seeking. We recently interviewed Richard Boothman, head of risk management at University of Michigan Health Systems, and he talked about the attitudes that healthcare workers and patients must have in the future for a better informed consent process. Let's take a look.
We have a daughter who is doing an OBGYN residency right now. And it wasn't so long ago that I remember when she did her first clinical exam. And she called me up, and the air of wonder and the weight of the responsibility that she felt in actually touching somebody she didn't know, someone who disrobed in her presence, that moment of awe has got to be something that is felt by every healthcare provider of every stripe at some point. That would be my first advice to any organization, is to stress the importance of never forgetting who we're all here to support, whether we're lawyers or housekeepers or someone doing a big surgery on a patient, that we have to find ways of moving this community from physician centricity to patient centricity in a meaningful way, not just with slogans and assembling groups of patient and family care advisors, but to literally embody that notion every single day, that every one of us here at the University of Michigan, for instance, has got to find a way to remind ourselves day in and day out that this is always a very special place for the patients that we're here to serve. That's cultural. That message has to start with leadership. It has to be overt, it has to be conspicuous, and it has to be reminded day in and day out. We know, for instance, that when human beings are involved in any occupation, it doesn't take very long to get desensitized to the specialness of that. It becomes a workplace for all of us that come to work every day. But when patients come here with their families and come here even for well baby exams, for instance, let alone because they're really in desperate need of some life-saving medical care, it's always a special event, and we have to remember that patient to patient to patient. So what are the patient's responsibilities? First, their responsibility is to take control over their health care, not to live a completely unhealthy life and then expect us to fix it when they get at a terrible crossroads. That's part of it. But secondly, it's also to be informed, to ask questions, to be accurate historians, to be conscious about it, not to walk in and expect us to read their minds, to speak up when they're uncomfortable or when they don't understand something. It absolutely has to be a shared endeavor, but ultimately it's their lives, and it's their lives that'll be impacted for good or for bad, depending on how things go. And they have an awesome responsibility, and I think we've done a pretty good job of de-emphasizing that over the years as we've crowed about all of our wonderful accomplishments. We have a heart surgeon here who, for instance, routinely tells patients, don't worry about a thing, I've done more of these procedures than anyone, you've come to the right place and you'll be fine. And of course that speaks exactly to what a patient wants to hear. Nobody comes to get medical care expecting bad things. Everybody comes here expecting the best, and we want them to expect the best, but we've got to do a better job of helping them envision what it's going to look like if it doesn't go well.
Another video that covers a lot of ground, and especially I like how he picks up on the paradox between a healthcare worker where it can be another routine day, and for a patient where this may be one of the most momentous days in their lives, and also the responsibility of patients to be engaged in their own health care. Patty, what were your impressions here?
Well, you know, patients being engaged in their own health care is our mantra. So we do community trainings, and jot this down. The trainings consist of teaching consumers how to be part of their healthcare team, understanding what patient safety is and its importance, being able to identify who could or possibly should not be an advocate for the patient, learning what the patient advocate should do. Consumers are taught how to properly communicate and partner with the healthcare team. They learn shared decision-making and what patient-centeredness is. And we discuss the culture of less blame and more solutions. Besides many other tactics and strategies throughout the 6-hour workshop, consumers come out of this empowered, engaged, and ready to activate. And that's what we want.
Yeah, you know, that type of workshop setting, I think, is something that many, many institutions and organizations can do. It's something that individuals in their practice environments can and should do. They don't necessarily have to do these 6-hour types of workshops, but some kind of structured approach in things. There's clearly a trend going on for sharing risk inside of our healthcare system. We're still trying to clarify what population health means, but the implication is there is we're looking after our health better. But within our ongoing restructuring of our financial activities and payment structures, sharing of the risk is there, and that's not just sharing on health, it's sharing on the downsides of it. So there's a significant potential economic impact here.
I was happy to see Rick Boothman, who is a lawyer and a risk manager, reflect the transformation that's going on by calling out the importance of understanding those shared risks and shared benefits. That was my main takeaway from this film.
So Patty, from a patient viewpoint, what constitutes shared decision-making?
Robert, so shared decision-making brings at least 2 experts to the table, the patient and the provider. The family members and other members of the care team certainly can be and may be involved. The provider is an expert in clinical evidence, and patients are experts in experiences, their own experiences, and what matters most to them. So shared decision-making is appropriate for any health decision with more than one medically reasonable option. So if you look at shared decision-making versus informed consent, first of all, ethically, it's the right thing to do. I think Marty had touched on that earlier. It really becomes a perfected informed consent because you have to have the shared decision-making with it. And it helps bridge health disparities, something that Peter is very passionate about. And it can impact the quality, cost, and safety of healthcare delivery, which the organizations are very passionate about.
Peter, can you describe for us the elements of a comprehensive shared decision-making and informed consent process?
Sure. Yeah, so this is a writable moment there. It's got to be team-focused. It really does. And even though it's ultimately that patient and the provider, it's still, there's a whole team set of activity around there, and we should be very mindful of that within the groups that are providing care, within the organizations, with the environments where these procedures are happening. And it's got to be respectful within all these different members. We should include a component and a recognition of the science towards evidence-based medicine. And true evidence-based medicine always has that moment where there is this kind of customization, if you will, of what's best for that patient. And as we go through that, we have to clarify for the patient or their family or their partner what's their role and encourage them to participate in this, because most aren't aware that they can. And then we re-describe the issue, the treatment options, the alternatives, the consequences, risk, benefits, harms, discuss the uncertainties in all of that. At some moment, try to figure out how much the patient's comprehending in all of this. And then as you get a sense of that, then elicit appropriate and reasonable statement of the preferences of the patient, and then you sign.
My best advice to you, if you're doing informed consent, is to listen and to probe. That's the only way you're going to get to what Don Berwick, I think, captured for all of us. No decision about me without me. You've got to get to that nugget of agreement.
Right. From a patient perspective, is there anything you would add to Peter's list?
I always can add things, although Peter did a great job. Facilitate deliberation, decision-making, and documentation. Example, if someone has stage 1 cancer, they have a much longer period of time to research, get their answers answered, and decide what they want to do versus someone who is in an acute, 4-stage area for that same disease. And then assisting with implementation of patient has done their goals, their preferences, what they want, guided with their physician's help, and then the physician to help get everything started.
And you can get there by listening. So listen to your patient for their questions. If they have no questions, prompt them. Sometimes patients don't know what to ask. Patty's talked about that. Assure them there's no silly questions, there's no silly concerns. And then listen to see if you think they're understanding the risks and benefits that you're talking to them about.
So I think as we tie this together, then it's a matter still of trying to incorporate what's best for the patient from the patient's perspective, what's best for the provider from the provider's perspective, there is this sense of urgency that Patty was referring to, and where on that spectrum or scale are you? But then the third piece, which we tend less to pay attention to, is the organizational setting in which you're working. And so all three need to come together in a uniform, consistent approach over time.
And do we have resources available for our viewers on this whole process?
Absolutely. There are tools, many tools. My favorite tool is this, which is a decision aid. And, you know, patients are unique. They don't look the same, they don't act the same, and they don't learn the same. And with this one, there is video for patients that, you know, learn by watching and also by reading, so either one. So this is just one of many. There are going to be other tools that are on the website so that you can take those from there.
Thank you all. You've provided some great information and resources in terms of what we can do to improve the conversation between physicians and patients in this important area. Appreciate it. Before we go in any further, let's get you involved. We're ready for you to join the conversation, and there are two ways you can do that. First, chat with us online. If you're watching on the web, just type your question or comment and click submit. Or you can send us an email at visientvideo@visientinc.com. We already have a few questions from the audience. The other thing I would ask is, if you do have a leading practice in this area, please communicate that to us as well. And we may run over a little bit because of the number of questions we have. We respect your time, but if you can stay with us, that would be great. So our first question is a bit long here. What is your opinion on the nursing staff getting the patient's signatures on consents? Physicians at our facility say that it is too disruptive to their workflow to get consent signed in the office, and when they're having the conversation with their patient about their procedure. And so the consent is signed the day of surgery, or a nurse comes into the clinic room after the surgeon moves on to the next patient to get the consent signed. I know this is not that infrequent of a practice. Thoughts, comments?
Well, it goes right to the heart of the productivity issues and everyone trying to be more efficient in their time these days. And yeah, you can rationalize why you don't want to spend that time with the patient, but in actuality, you're harming the patient by not spending that time, and ultimately you're also harming yourself and the integrity of a practice. If it's any individual who's doing the procedure, it's ultimately, in my mind, that individual's responsibility to obtain the shared decision-making, to obtain that consent, and using surrogates should, if they are going to be done with full disclosure for everyone involved. But it's a disrespect, to the patient and ultimately to your own practice if you don't do it.
I think it's also putting a nurse in a position where he or she shouldn't be. You know, they are not doing this procedure. They may not feel comfortable explaining everything that needs to go into this.
May not be able to answer all the questions.
Right. And, you know, maybe using nurses coming in and doing a teach back with them to see what they understood may be appropriate, but not to be given the consent.
I'd be happy to have a nurse take the consent if I've had the conversation with my physician in advance that I'd want to have with that physician. If the handoff is there to the nurse, I'm fine with that, but not as a substitute for having that conversation with the doc who's the head of my team.
So would you have the nurse ask then ahead of time, patient, are you comfortable with what you know about this procedure before they obtain that consent? I mean, your answer kind of implies that.
I would, Robert, and I would say that it's the system's point of view, the organization that you're in, to almost require that, to say that nurse has to make the handoff conversation connection between the patient and the physician to make sure that that's happened.
Let's not forget that there are also scope of license issues, and every state is different, and any institution may have its own scope of licensure and responsibility, and you know that all needs to be very, very clear for everyone involved, and especially the patients.
Well, that is part of the problem, Peter. There is great variation in law from jurisdiction to jurisdiction here, but that is part of the urgency also to move forward and change some of that
medical
policy.
staff bylaws as well.
Right.
Yes.
Right.
Okay, next question. Do you know of any models of informed consent where risks are not just presented as broad risk, but risks are taken into account the patient's unique comorbidities, if you will, medical needs, and how they may impact or change the risk from what is typical for a given procedure.
Well, that gets back to what I was talking about, evidence-based medicine. You know, you've got the condition that's being treated, the treatment, but you do have to factor in comorbidities, you do have to factor in other elements of that patient's life, lifestyle, etc. And then you come up to what's the right decision for that patient given all of that plethora of activities. And it gets complicated. And sometimes, you know, what a provider would hope was a 5-minute conversation becomes a 50-minute conversation. And that's why we get some of this resistance to want to be very thorough in our consenting processes, let alone shared decision making.
Right, and that's what I was going to say. That's why you have to have the two-way conversation of the shared decision making. So everything rises to the top, and you're not going in as a physician, which I would consider a liability, without knowing all of the information.
Right.
And I would just add that patients aren't generic. I mean, we do have our own values and preferences that we bring to this. I mean, I may choose not to do recommended medical care if I'm 87, have other comorbidities, and have led a good life. I'm projecting a little bit, but you know, you can't assume that everyone wants the same thing. That's the course of shared decision making.
Yeah. We've had several shows this year on patient and family advisory councils and engagement. So here's a question. What is the role of a PFAC, a patient family advisory council, in this process? How do PFACs impact shared decision making and the informed consent process?
Well, I'm a huge fan of PFACs. I think PFACs are an underutilized resource in general, but in terms of setting policy that's authentically patient-centered in your organization, if you've got a PFAC, you've got the infrastructure to do it. So I would take this to the PFAC. You will be surprised at what you hear from them.
You would take the actual consent document or the process itself?
I'd take both. I'd take the process and say, does the document reflect the process? Is the document one you'd understand? Think of a PFAC as a focus group, a standing focus group in your organization. You can take anything to them. We don't take enough of our documents and our brochures and our public communications to our PFACs. They're an inexpensive resource that hospitals should use more, hospitals and physicians' offices, I would say.
They're pretty priceless as well.
Not just for wallpaper and menus,
yeah,
right?
Really.
Okay.
It kind of makes my hair stand on end. Yes, you're dealing with some really, I mean, it's your customer.
Yeah.
They will tell you what they want.
Well, and a committed customer.
Yeah, no, absolutely. But they are also advisory. Mm-hmm. You know, and so you take the information in, you utilize that information, and that helps you to build the integrity of not only your process but your documents. And it puts in I don't know what the right word is, it's a reinforcement moving forward that there's been a process around these documents and the process, so that people can be reassured this isn't just some organization or some practice that's made this up.
And Robert, another secret about PFACs is that they are community members. So they go back out into their community and they say, wow, you wouldn't believe what this doctor's office is doing or what this hospital is doing. They're actually asking us about the things that really matter to us, and you find them becoming, sharing that goodwill out of the community.
So one of the things Dr. Krumholtz talked about in his video was better leveraging technology. And our next question asks, for institutions that have put informed consent on the EHR, what have been the benefits and challenges from this switch from paper to the EMR? Any notable benefits there?
This one's a double-edged sword. In some ways, it can streamline process, but in other ways, it's subverting the opportunity to have the dialogue. And so I would view that if you're going to use this kind of a tool, there might be some pre-conversation information sharing with technology, have the conversation, and then you can do a step-by-step technology-based consent if you need to. And that can truncate some of the process, but it's not a dependency nor a replacement.
I think the EHR in combination with a portal, if you've got a portal, you can give people more information through the portal to help them prepare for that conversation. It can make the conversation go faster. Again, the EHR shouldn't be a substitute for that conversation. Not everyone uses portals. Not everyone is electronically connected, so you might have to do it otherwise, but there's potential there for it to streamline the process and systematize the process.
Would you do it, Patty?
Yes.
You like technology?
Yes.
Okay.
And I use a patient portal.
Okay.
And I see that you can use a patient portal for decision aids.
Yeah,
So-
resources like that
Yes.
could reach not all your patients, but some of your patients.
Right.
Right.
Next question, I'm going to rephrase it a little bit. How would you handle consent for minors for treatment that exists in some states? Let's talk about consenting minors. What needs to be done when we're doing that? Legal guardian, adult, advocate, and in terms of this process, how much do we actually engage the minor versus the person who's going to sign the document?
Yeah. Well, you do need to know the law in your jurisdiction to answer that question, Robert, and there is variation from jurisdiction to jurisdiction, so that's point one. But then again, you go back to the basics. Is this child, this minor, someone who can understand the conversation? Do they have a guardian? I would certainly never hesitate to bring the guardian in. I know that gets a little dicey in mental health issues and issues having to do with reproductive health and things like that. But I would say where there's the opportunity to bring the patient, the guardian or the family or the parent in, do so.
I absolutely agree. And even though Michael was 22, I mean, we're talking about brain surgery. I don't think he was the one, especially if there was something wrong with his brain,
Cognitive function.
cognitively, that he
Right.
should be the one signing or reviewing this stuff. Not that he shouldn't be involved, but that there has to be somebody else there
So
as well.
this is really complicated. This is really, not only you have to understand the law, you have to worry about different age groups, and even if you're 18 or above, as you just highlighted, doesn't necessarily mean it's the appropriate way to go. And then what is the degree of autonomy or independence that that minor has already established? And then, how do any of us as organizations or practitioners make a judgment call on the quality of that relationship between that minor and their guardian? That's not really our role, but it factors into all of this.
And the other thing I'll add here is, as an anesthesiologist taking a child back to the operating room, this is another opportunity to talk to them about what's going to happen and what to expect, and treating them with dignity and respect and allowing them to go through a very traumatic time in many cases, at least with some knowledge and some conversation going into it. So it's not just the informed consent, it is the shared decision making, and it's the information they need to perhaps have a better experience.
It is complicated, but if there are patients and family members who are watching this, and let's face it, even providers are patients and family members, I would never let a loved one go into any kind of a decision-making process without me being there. For the reasons that Patty's mentioned, for the reasons that we've all mentioned, you're not at your best when you're in these conversations. You really benefit from having a family member there with you listening, assuming that you've got a family member that you trust.
I'm just going to remind the audience we're going to go right up to the half hour with questions, and then we'll close the program, so we may run a minute or two long. Are there CMS or Joint Commission requirements for the informed consent? I believe the answer is yes, but I'm not sure that those requirements address the shared decision-making process that we've talked about today.
But there is policy coming down the pike from CMS. CMS is very, very interested in shared decision-making as a part of an overall patient and family engagement. They call it person and family engagement strategy. They announced it last October. It's still being drafted. But they are building person and family engagement into their overall quality policy because they do think it's going to improve results. And a huge portion of that person-family engagement is going to be shared decision-making and co-creation of the treatment relationship overall.
CMS is a great incentive for us. Other payers are strong incentives for us. Accreditation is strong incentives for us. And yet, it's just the right thing to do. It's just the right thing to do. And it gets back to the integrity of your practice, your organization, and what's best for the patients ultimately.
We have just about 30 seconds left here, so I'll try not to use it all reading the question. Should not informed consent be a conversation, not a form? I think we've addressed that. The form should only validate that this discussion of risks, benefits, and alternatives has been discussed. Affirmation?
Amen.
Yes.
Absolutely.
Yeah.
Shared decision-making, though, the nuances, that's all the way through the course of the treatment of whatever the condition is. consent is for that moment of a treatment. So they're part and parcel together.
Okay, great. Thank you all. If we have not answered your question, we will do so after the show, and we'll post it on our show so that you do have the answer. And we appreciate all the input from our audience. We're at the end of our program. We hope that this has encouraged you in your efforts to advance the partnership between physicians and patients and see the benefits of greater cooperation when they do enter into the shared decision-making process. Peter, Marty, Patty, thank you all very much. Great panel, great discussion and perspectives of our topic. And thank you for sharing time with us today. Also, we want to thank Dr. Harlem Krumholtz and Richard Boothman for granting interviews to us, and thanks to the Vizient Hospital Engagement Network for their ongoing support of this series. If you registered in advance, the program evaluation will be emailed to you. Please take a moment to complete it. We do use those very much to construct new programs. And for those who could not view today's program live, it will be posted on Vizient's website for on-demand viewing. The address is at the bottom of your screen or in your supplement. And now, from the Partnership for Patients and Vizient, I'm Dr. Robert Dean. Thank you for watching today.